Hello, my name is Peter Hart from Endomed. What we will be discussing today is the Sengstaken and Blakemore tube. This is the tube that is a last resort and is for a catastrophic bleed of the esophagus. So what we're going to talk about today is the operational side and the functionality of it all. So I'm going to start from the beginning, and what we have down here is gastric suction ports. We have a gastric balloon, we have esophageal suction, and we have a esophageal suction port just there. Now when we go to the other end of the device, in clear we have esophageal balloon insufflator, which is marked in black. Then we have esophageal suction port, this one here. And what we then have is the blue, which is red on blue. We have gastric balloon insufflator. And we have then a gastric suction port just here. Now, when you receive the device, it has a stylus, which is a heavy gauge wire, which starts at the proximal end and goes all the way down to the distal end of the device, which is here. The reason for this heavy gauge stylus is once upon a time we used to have to put this in a refrigerator to stiffen up this distal end portion so it doesn't retroflex in the esophagus. So the way they've gotten around that now is this heavy gauge wire. What we do is we push right to the distal end, a little lock fitting there, and what it does, it stiffens up this distal end portion just here. So therefore not allowing it to retroflex into the esophagus. Now, in a perfect world, what we will do is we will test these balloons, but in real life, it's an absolute emergency, but we won't have time to test these balloons. We've never had any failures, but I'm going to show you how to do it anyway. So what we will be using is a 50 ml slip lock syringe. You can use luer lock, but I prefer slip lock. Then what we have at the proximal end of it, and we're just going to make sure these are nicely capped off and clipped off, just like we've done there. This is a one-way valve just here. So what we're going to be doing is pushing air, and air only, via our 50 ml syringe through this one-way valve, and we should see the distal end inflate just like so. And we're going to do the same with the esophageal balloon. Again, we're just going to be using air only, 50 mils or thereabouts, and this is the clear one. We're going to make sure this is capped off just at the end like so, which we've done. Again, this is a one-way valve here, so what we're going to be doing is just pushing some air through the system, just check the integrity of the balloons, which we have done. So the balloons are okay. Again, we've never had any failures. You probably won't have time to do this, but it's handy to know anyway. So now what we're going to do is a reverse procedure, and I'm going to just take the air out of the esophageal balloon, just like so. We're going to take the air out of the gastric balloon, which is the blue one, just like so. And now we are ready to insert the device. Now, how far to insert it? Okay, what we have is we have markings along this insertion tube here, and the maximum marking is 50 centimeters. Now that 50 centimeter is from the proximal side of the gastric balloon, not the distal or not this end here, but the proximal side. That's where that 50 centimeters starts. So this can be inserted orally or nasally. For this tutorial, we're going to pretend we're going to do it orally. So what we then do is we put some gel on it, just like so, and we're going to insert this orally. Now, because it's a catastrophic bleed, by putting an endoscope down, all you will see is a red out. But if you can put it down, put it down. But if you cannot, we just have to go in blindly, and that's where the doctor and the anaesthetist will work together on this one. So what we do is we put some gel on it, just like so, and we insert it orally, and we go down to the 50 centimeter mark, which is just there, and that is from the lips. Now this will be curled around in your stomach, just like so. So once we have done that, then we get our 50 ml syringe, and we're going to inflate the gastric balloon. Now the maximum allowed pressure from the factory is 300 mils of air. For this occasion, I'm only going to put 150 in or thereabouts. Now, if you put in a little bit more, a little bit less, it doesn't really matter because it's a gastric balloon. The most important balloon is the esophageal balloon, and that's where we have to use a different device like a manometer, but I'll get to that very shortly. So what we simply do is use a 50 ml syringe, and that's the syringe I recommend, because if you use a 20 ml syringe, it's hard to keep count. So we go through this one-way valve here on top, and we're just going to insert, there's 50, there's 100, and this is 150. And you can see the size of that balloon right now. So when it's fully inflated with 300 mils of air or thereabouts, the balloon is going to look something like this. Now at this point, what you would do, you'd pull back to the junction, just like so. Pull back to the junction, and then we will get our trachea tape, which this one here is only short, but what we then do is we go around this portion here, tie that into a knot, just like so. Then this other portion, which will be longer than this, of course, this will go over an IV pole at the foot of the bed. Now, for the traction, what we use is a 500 ml saline solution of water, and that is the maximum recommended amount of traction that we can put on this device. So that will then pull that back to the junction where the varices probably is going to be. 95% of the time, you'll only ever have to inflate this gastric balloon. On the rare occasion, you will have to inflate the esophageal balloon. Now, how do we know this? Okay, so what we have here, at this end here, we have esophageal suction port, just here. And then we have to then put a spigot in, just like so, push that in, then wall suction onto this portion here. Now what we're going to be doing is sucking from the esophageal suction port, which is just here. There will be some blood in the esophagus, there's no doubt about it. So what we're going to do is we're going to suck all of that blood out, and if it continues to bleed, then what we have to do then is inflate this esophageal balloon. If the bleeding stops, then okay, that's all we have to do. We've controlled the issue. So let's pretend that it is still bleeding. So what we have to then do is inflate this esophageal balloon. At this point, we never ever use this again for the esophageal. We never use that. What we will be using is a manometer, and it's calibrated in millimeters of mercury, mmHg, and the maximum allowed pressure is 40 millimeters of mercury. That doesn't mean we're going to go straight there. What that means is we're going to go up in increments first, because we don't want to overstress the esophagus. Now, to inflate the esophageal balloon, it's going to be the clear marking with the black writing. Now, unfortunately, it doesn't fit all that well in this little one-way valve. So what we're going to be doing is going to go through this side port here, just like so, and unclip that, just like so. Just remembering, this is a one-way valve. There is no one-way valve on this side port, so we'll have to include that once we get it up to the pressure, desired pressure. So what we're going to do is we're going to then inflate that to 20 millimeters of mercury, and we'll just do that right now, and you might be able to see the esophageal balloon is inflating, just like so. Now, once we've got it to 20 millimeters of mercury, then what we do, we keep an eye on this esophageal suction port here to see if the bleeding has stopped. If it is continued or reduced, then we go up in increments of 10 points each time, remembering 40 is the maximum allowed pressure. So what we're going to do is just go up another 10 points, just like so. And if it continues to bleed, we're going to go up to 40 millimeters of mercury. That's the maximum allowed pressure, and that should be enough to stop any sort of a bleed. And to confirm that, what we will be doing is just having a look at this esophageal suction port, which is this one here with our suction on that. Now that should resolve the issue. So at this point, what we do is we continue the suction on the esophageal to confirm that it is stopped, the bleeding has stopped. So then what we then do is we then clamp that off just like so, pull this out just like so, and just cap it at the end. Just like that. Okay. Now, at this point, what we will be doing is removing this heavy gauge wire, because we've controlled the bleed. We don't need this wire anymore. We just pull that out. Then we pull this portion out here, So it's looking like that. Now, at this point, what we can do via our gastric suction port, if there is any blood in the stomach and we want to remove that, we put our spigot onto there like so, wall suction onto there, and we will be sucking from this portion here and just removing any blood that is in the stomach. Okay, once we have done that, then what I would recommend is we always put a drainage bag on this portion here, because what will happen, it will siphon out and will go all over the bed, and that's not a good look. So we just put a drainage bag onto that, and they're readily available from anywhere in the hospital, I would imagine. Now, what we have here is some little white lines. You can see that one distal, proximal, distal of the balloons, and proximal of the esophageal balloon. Then we have this white line which goes down the actual tube itself. Now this can be seen under x-ray just to confirm that the balloon is in the correct position, but under an emergency like we've just had, we will not have time to get x-ray up, so we have to put it in blindly. If we can put a gastroscope down to confirm that it is in the stomach, that would be great, but generally it's going to be a red out and you won't be able to see anything anyway. So that's why it has to go in blindly. Now a little bit of housekeeping, what we have to then do is make sure that we make some measurements, and these measurements on the actual insertion tube, what we do is we measure how far it is from the lips to make sure that it is not migrating up or down. That's just one thing we have to do. And also what we then do is make a note of how much pressure we put in the gastric balloon and also the esophageal balloon, if in fact it has been inflated. Okay. So what I'm going to do now is, just for an exercise, I'm just going to deflate the esophageal balloon, just like so. That balloon has now been deflated. Now what we have on the insufflation side is we have what's known as a pilot balloon. Now we do know that we have pressure in the gastric balloon, we do know that. So this balloon is puffed up and we can actually feel the pressure in there. So that's just a visual confirmation that we do have pressure in there. Now what we do know is there's no pressure in the esophageal balloon, and you can see there is no pressure in here, so that's a visual effect of saying there is no pressure in there. Okay. So that's what we've done so far. Okay, now the pressure is off. Okay, so at this point we'll probably go to ICU. Now what ICU will be doing is they will be managing these balloons now. So once they've got all the information of how much pressure is inflated in the esophageal balloon and gastric balloon, then what they will have to do is manage that. Now with ICU, they have to relieve the pressure probably every 2, 3, 4 hours, that's depending on their process. Now to do that, if the esophageal balloon is inflated, we deflate it, we release the traction from our 500 ml saline solution. We never deflate the gastric balloon unless we're going to take it out. Now the reason for that is there was one sad occasion, the patient was okay, but they deflated the gastric balloon and reinflated in the esophagus, and that was not good for the patient. The patient was okay, thankfully. So what I'm saying is when we deflate the esophageal balloon and we have to relieve the pressure, we just simply push it forward for 2, 3, 4, 5 minutes, then reapply the pressure again. This is an ICU call on what sort of timing they want to do that. Now the only time you would ever deflate the gastric balloon is when you're going to take it out. That's the only time. It's not a difficult device, but if you don't use it every day, it can become difficult, because you might only use it once every 6 months. You may never use it, but when you need to use it, it's a life-saving bit of kit. So that's why we all have to get together and understand what these pressures are and make sure that we are inflating this gastric balloon in the stomach and not the esophagus. So that's why we have to get together on that. So that's it. So if there's any questions, we'd be happy to answer them. Thank you for your attendance.